Hello, and welcome to another episode of the Virginia Dental Association's podcast, The Fulcrum. My name is Karen Wood, and I'm the Director of Operations for VDA Member Perks, which is the member benefit program for all VDA members. Our endorsed vendor partners provide discounts on products and services, as well as an elevated level of support and attention to the VDA members that use them. For all matters involving insurance, we are fortunate to work with the team at RK Tongue Insurance. They have been dedicated, loyal, and a proven partner in advocacy and support to the VDA and the Member Perks program. One of the many advantages of working with RK Tongue is their commitment to education and guidance for dentists. Today, we're going to be getting some expert advice on the topic of dental malpractice and review some of the more common types of claims that are happening now and how to avoid them, what you and your team can do to protect the practice, and how to proactively use the resources and experts that a policy through RK Tongue offers. Recently, RK Tongue announced the launch of Dentist Choice Malpractice and Office Insurance. And in the process of researching and getting myself familiar with the offerings available from Dentist Choice, I was impressed to discover the tools and resources available to our members. I was even more impressed when I found out that the head of dental risk management for Dentist Choice is Virginia's own Dr. Rizkalla. The VDA gets to proudly claim him, as we have benefited from his leadership for many years in many positions, including his time serving as the president of the Northern Virginia Dental Society, having him on the VDA board, and serving as the VDA's chair on the Council of Ethics. He was also president of the Virginia Board of Dentistry, and after 30 years of private practice, Dr. Rizkalla is very excited and passionate about his teaching role as an assistant professor in the Department of Comprehensive Care at the Howard University School of Dentistry, where he instructs interdisciplinary healthcare ethics to medical, dental, and pharmacy students. I could continue for a while listing more of his accomplishments and impactful positions held, but my point was to demonstrate the extensive experience that Dr. Rizkalla brings to his role with Dentist Choice. So I'd like to welcome you, Dr. Rizkalla, to the VDA's podcast.
Thank you, Karen. It's an honor and a pleasure to be here.
Well, I was very excited to have the opportunity a little while ago to pick your brain, Dr. Rizkalla, and you and I discussed some of the common areas where dentists find themselves in trouble in terms of opening themselves up to an accusation of malpractice. Having worked in a dental practice as a manager and as a chairside assistant, it really hit me how daily interactions with patients, the impacts a busy schedule can have on recording details for proper documentation, and a simple lack of information can lead to problems. So let's start with the patient interactions and dive into discussing treatment plans, option in those plans, and how to properly obtain consent.
This is an area where we can talk for hours and hours, but let's start with consent, since you mentioned it, informed consent, and I see it a lot on cases that come before the board and cases that become legal, which is the lack of informed consent. Informed consent is all about a discussion that you have with the patient. You're supposed to first have a discussion, then you document the informed consent. And I see a lot of cases where it says lack of informed consent, lack of comprehensive treatment plan. You know, so many offices, they have just a piece of paper and a team member that is not familiar with the treatment that's going to be performed. They present it to the patient. So you have really 5 elements of the informed consent, and all 5 elements have to be there for the informed consent to be valid. First, the patient must be competent. The patient must be able to understand the information and has the ability to reach a decision on their own. That's the first part. And of course, the second one is the disclosure. You know, you want to explain the proposed treatment, the alternatives, the other options, the risks, the benefits, and a lot of time we forget the prognosis and possible potential complications. And what is the risk if you don't do the treatment? And you want to answer all the patient's questions. A lot of the problems that arise with patient interactions, they're money related. So as you talk about the informed consent with the patient, go over the cost, the financial obligation. One of the most common reasons for claims against dentists is financial issues. Have a conversation about the cost early on, so the patient understands what's happening. One of the things that's really important for everybody to understand is informed consent is for the benefit of the patient. I'll repeat that. Informed consent is for the benefit of the patient. You don't want your your personal bias as you're presenting the informed consent. And as you're having this conversation, this is a great time to manage the expectation of the patient and see if the patient has unrealistic expectation. This is the time to find out before you embark on treatments. Then you have comprehension. The first one was competence, but then you have comprehension. The patient must have the ability to understand, so if a patient is in severe pain or they're anxious or they're distracted, these are factors that will impair their comprehension. And you need to keep in mind what's going on. If the patient is sedated prior to this, then you have an issue for their comprehension. And of course, it has to be voluntary. When you present the information and you're having this discussion with the patient, you want it to be void of deception, coercion, or manipulation. And then, of course, the last thing is authorization, which is the patient has to authorize, and it has to be verbal and by signing. And of course, a lot of questions that we get is, should a witness be there? It's a good idea to have a witness. It improves the validation of the informed consent. A lot of what we do really relies on the ethical principles by the American Dental Association, patient autonomy. This is one of the main things why, informed consent is there. The patient has the right to choose and be part of what happens in dental treatment. Non-maleficence, beneficence, justice, and veracity. I mean, if I can talk about the ethical principles for a long time, I can, because they provide guidance and justification. They're the moral of campus, and they provide a lot of safeguard for what we do. And of course, finally, what we talked about, which is voluntary. The patient needs to verbally agree and sign for it.
Yeah, and going back to something you mentioned earlier about, patients could have concern for finances, and you're disclosing what that is to the patient. And they want to pick and choose which treatments that they want to have based on that. How much say do they have in that?
Let me answer this by telling you a story. Patient walks in with a loose upper and lower complete denture. This is an actual case, by the way. And the dentist looks at the case and says, you know what? These dentures, they need to be redone. And the patient said, no, I am saving my money because I want to get implants and I want to get dentures over it. I want you to do something temporary to hold me over until I'm ready to do that. The dentist said, no, it's not going to work. Whatever I do is not going to work. So the patient insisted. The dentist decided, you know what? Okay, I'll do it. After all, it's a temporary fix and I'll do it. So she ended up doing a soft reline for the denture. And the patient walked out. Next day, the patient called and says, I want my money back. This is not working. Well, the dentist said, you know what? I informed you and I told you that it may not work. And it didn't work, but I told you that it's not going to work. The patient said, well, I paid you. I want my money back, and started yelling. The dentist said, you know what? You are yelling. We cannot have a reasonable conversation. Don't call back. And they ended the conversation. The next thing you know, the patient filed a complaint with the board. And now the dentist has to go through all the steps of the complaint. But that's because the dentist went outside. The patient insisted, and the dentist said, okay, I'll do it. And many cases like this, you're the dentist, you're the one that went to school, you're the one that's obligated to follow the standard of care. The patient should not dictate the treatment. I mean, you can do things that are within the standard of care if it's option 1 or option 2, but your judgment is what reigns. Did I answer your question?
Yeah, and staying with that, if the patient requested a refund of their money and the dentist decides to do that, is that any kind of admission of wrongdoing on the dentist's part?
Yeah, excellent questions. Wow. Okay, so you want to have a conversation with the patient. If you're planning on doing a refund, you want to have a conversation with the patient, and you think of it as a business decision, because sometimes giving a refund could be a wise business decision that will avoid escalating things. But you want to have a conversation with the patient, and then we talk about signing a release, because without signing a release, sometimes that could be construed as admission of guilt. Signing a release, the dentist has to make a judgment call each time, because sometimes, depending on the situation and the case and the treatment provided and the amount of money that you're refunding and so on one hand, it's a business decision. On the other hand, you may raise a red flag in the patient's mind. What am I signing? So for dentist choice, we go case by cases, and you want to call a risk manager early in the process, whenever this happens, so we can go through the steps and assess the situation and give the proper advice.
And it sounds like the
Go
dentist should
ahead.
be the one having the conversation with the patient, not the office manager. Is that right?
Amen. Amen and amen. Thank you, Karen, for
Oh,
pointing
I'm
this
just
out.
telling, no, there's no office manager that wants to have that conversation. So you're just giving permission away.
But so many people, they just let the office manager deal with the patient, and having a third party in between, sometimes it escalates things. When there is a patient that's not happy, the patient wants to be heard by somebody that provided the treatment. Sometimes it's delegated to somebody that's not providing the treatment, an office manager, but sometimes uh, pride gets in the way. And you really want to de-escalate the situation by providing a safe space for the patient to voice their concerns and listen to them, and listen to them actively and with empathy, and put yourself in their shoes and treat them as you would want to be treated.
That sounds like a good practice to have. And back on the documentation, because of course this is all going to be in the records for the patient. We didn't talk about x-rays and how to present x-rays and how to document what you find in the x-rays. And then there's also the overlap bite wings, or something that's cone cut, or a PA that doesn't show apices. What's the best way to handle that?
Well, you always want diagnostic radiographs.
So if a
Um,
patient is difficult, has tori, it's almost impossible to get that. It's okay to leave with that x-ray and they document why the x-ray is that way.
You can, but you can always also resort to extra oral, like a Panorex or something like that, to complement it. I mean, you don't want to just keep exposing the patient over and over to some x-rays unnecessarily when you're not going to be able to get it, whether it's, the patient is in pain or there is a huge torus or something. But you can always resort to an extra oral and document this. And by the way, you don't keep charging for it. If the patient is refusing radiographs and you cannot make a diagnosis, we will have a conversation with the patient. Often I find, if discuss a little bit of finances and, Mr. or Mrs. Patient, we really need this radiograph to make a diagnosis. And in order to treat you properly, I need to see what's happening, and we'll do it on the house. Sometimes this is the concern, and the patient say, okay, go ahead. In special circumstances, let's say a patient comes in and says, I may be pregnant, and if you know the patient, you know the circumstances, you can forego radiographs, 1 or 2 visits max. And I'm saying 1 or 2 visits, not 1 or 2 years, 1 or 2 visits. Other than that, it may be time to dismiss the patient. The standard of care required that you have radiographs to make a diagnosis.
Now, in the realm of documentation, and someone files a board complaint and, an investigation is opened, what does that look like for the dentist? Because you may have good documentation on this one patient, but from what I understand, it doesn't stay there, that they look at other patients' charts. Is that correct?
Yes.
Okay.
Oh, yes. When a complaint is filed, an investigation is started by the Department of Health Professions, the investigative unit. That's aside from the Board of Dentistry. They investigate, they collect records, they get not just one chart, but several charts, because they want to see the quality of care. and I'm going to stress this here over and over again. Good documentation equals good care. I'm going to say it again. Good documentation equals good care. So we can talk about documentation a little bit more. Actually, we're talking about this collecting more charts. Here's a case that actually is in progress right now in another state. Due to a billing concern, a patient filed a complaint with the insurance company. The insurance company decided to do an investigation. So they went in, and not only they collected the chart of this one patient, they got 25 other charts. 25 other charts. And they looked at them, and they discovered from the documentation of all these charts that the patients there are not getting good care. So after they did their thing, they actually pushed this case over to the board of that particular state. Now, I went on a tangent. I don't know if I answered your question or did I miss part of the question?
No, you did. And another question I have about looking at charts, does that include the ledger? Because we just discussed not charging a patient for x-rays.
Okay, so if you do something at no charge, you don't have to put it in the ledger, but it's advised to put it in the ledger, and you put in no charge next to it. Accuracy matters. And I think if your records and your ledger go hand in hand, it shows that this is an accurate practice and everything is recorded. As a principle, if you do something at no charge, also put it in the ledger and put no charge next to it.
And what's your opinion on using templates in the practice management software for the basic procedures that the doctors do all the time?
Templates are great. They save time. And if you take your time and use the templates properly, it's great. A lot of practitioners delegate the records and using templates to another member of the staff for, time and so on. Documentation and records are the responsibility of the clinician. No doubts about it. Doesn't matter who wrote them, but they are the captain of the ship. And whatever in documentation you using templates or not, if you use a template, and I'll tell you a case that I'm dealing with right now where the template is used and they cemented the bridge, and on there, the template says there is cementation of bridge, Relax, and Unisem is used. And both of them are in the template. Somebody didn't look at records. Every entry has to be the unique encounter with this particular patient. So templates are great, but you've got to read them, make sure they are correct, and sign properly. If there is a mistake, document why we're making a mistake, put in this entry here is amendment because the other entry, and explain what it is that you're correcting.
Okay, and let's discuss medical history paperwork. It's been my experience that some patients give limited medical history information or don't disclose over-the-counter medications or vitamins they use regularly as they see this is just a dentist visit. What do you suggest for reviewing medical history to make sure you're uncovering necessary information the patient maybe didn't feel like they needed to disclose, and maybe some examples on when to probe further?
Medical history, one of the most important things these days. I mean, I got to tell you, it's a huge and important steps in risk management. Today, people are living longer, taking more medication. I mean, every week there's a new medication that's being introduced, You got to pay attention to medical history and document it properly. I mean, you have a patient that's 5'4", 300 pounds, 60 years old, and they check no to everything. I'm going to ask questions. And when you ask questions, you generate more answers. We all got this lesson in dental school, but we need to remember it, especially in a busy practice. You want to be sitting at eye level with the patient, and your body language needs to show the patient that you're interested in what they say and providing safe space for them. If somebody's taking, for example, Lexapro and Prozac and whatever for some medical reason, and maybe they don't think it's important to disclose this to the dentist, you want to go over these things and let them know that, yeah, this is a safe space. We're not just treating the mouth. The mouth is connected to the rest of the body, and we need to see all of this and talk about this. And by the way, this is a great time for risk identification. As you carry on a conversation with the patient, you can see if this is a good indicator of the future dentist-patient relationship and make a decision on that. Yeah, medical history is so important. And another thing and this drives me crazy, when you update the medical history, I don't like the N/C, no change. No, that's not enough. You want to ask the patient questions. You want to say things like, have you had any doctor visits since last time you were here? Let's go over the current list of medications and supplements that you're taking. Have you had any hospital visits since you were here last? Have you had any imaging since last time you were here? And document all of this.
So what if they tell you that they had a knee replacement 6 months ago? It's a new patient. When you're looking for that kind of documentation and if there's going to be antibiotics needed before dental treatment, and you have to confirm that with the orthopedic surgeon, I'm assuming. Do you have to have that in writing, or can it be documented from over the phone?
I would prefer to have it in writing. You have documentation. If you happen to have a phone call, document who you spoke with and what time, but I prefer to have it in writing. And especially with knee replacement, I want the orthopedic surgeon involved, because orthopedic surgeons, yeah, the American Dental Association says you don't need to pre-medicate, but knee surgeons, some of them, they want the patient pre-medicated for the rest of their life. My wife's is one of them. Her orthopedic surgeon, and I had a discussion with him about this. I had a heated discussion about it, but he said, I don't care. I want her pre-medicated with antibiotics before dental treatment for the rest of her life. I actually got that and put it in her chart. And I said, I need this. And by the way, would you please call in the prescription yourself, whatever you want her on?
Speaking about, specialists and documentation, let's talk about when the dentist refers to a specialist, and we can use an endo referral as an example. What should be in the chart about the decision to refer, and what should be on the referral slip sent to the endodontist?
Another excellent question. So specialists in general, they can be your allies, but you need to know when to refer and when not to refer. What do I mean by that? When to refer, meaning I know that I'm going to practice within the limits of my ability. If I don't have experience taking impacted third molars, I'm not going to begin doing surgery. I'm going to send it to the oral surgeon. If I see calcified canal on an elderly patient and the canal is not clear, I'm not going to start. You don't want to refer to specialists only when you're in trouble. That's not good practice. And the other thing, you also have to exercise judgment, and this goes into my second point. You're the quarterback. The specialist that can be your biggest ally, they need to know your ethical and competent behavior. So you have a tooth that has a vertical fracture that's visible on the x-ray, and you send it in the data, say, can you save this? I mean, this doesn't speak well. You want to communicate specifically what you want the specialist to do, not just say, please evaluate or something like that. You want the periodontist to do crown lengthening, and you have a tooth that has a hopeless prognosis. That's not good referrals. What you want on the documentation, on the referral form, and the patient needs to understand is, I am going for XYZ. Now, what comes back from the specialist, if something that they cannot do or what have you, that's another story. But you have to have enough specificity in the referral form that this is what you want them to do. And you want to obviously document everything. A copy of this goes in scanned and goes in the chart, and a copy is given to the patient. And also in any communication with the specialist, say you're doing endo on a patient and something happens and you stop in the middle of the procedure and you go make a phone call. You want to document this phone call and whatever advice you have given. Let's say you're doing endo on number 30, and you may have irrigated a little too much with hypochlorite, and the patient started feeling something. and you get scared and you stop and you go call your friend in the down and say, oh, what am I going to do? I says, well, at least, go irrigate it now with some local anesthetic. And you go do that. Well, you want to document this conversation, and this is the advice. I'm just using this as an example, Anyway, go ahead.
Right.
I'll keep prattling.
No, we
Ask
could
me your
stay.
next
We could
question.
stay in the weeds all day long, but maybe let's go big picture for a minute, and you can tell us what the most common claims that you find are being made against dentists.
Well, let me tell you one thing. I think I mentioned this earlier. Regardless of the claim and dissatisfaction, a lot of it starts from finances. That's what instigate this. Whether there's a billing issue or whatever, then you have a claim. But as far as the severity of the claim, sedation is a big one. Third molar extractions by general dentists. I mean, this is from the National Advisory Council with third molar extractions and temporary or permanent paresthesia. Almost 80% is due to general dentists practicing outside their scope of practice. Sedation, not following the proper recommendation or the proper training, making sure you monitor the patient and you have all the equipment and you have the right number of staff, trained staff, the right post-operative instructions. And this is a big one for me personally, is the all-on-4, what they call or all-on-X. And I think I wrote an article in the VDA Journal about that. You want to make sure that you're selecting the patient properly. Doing things, aesthetics, that's another frequent thing. And you see veneers being placed in the patient with periodontal disease or improperly done veneers. Yeah, those are common things.
Okay. Let's go back to something that I mentioned in the opening about resources that are available for the clients of RK Tongue that use Dentist Choice for their malpractice insurance. I saw on their website a couple of sample letters to use for dismissing patients. One was for non-compliance and another for not being able to reach a patient of record. Let's start with the patient that the front office has left messages for that has some minor outstanding treatment or is pretty overdue for a hygiene visit. And, an office manager, they're going to want to make sure that the active patient count is as accurate as possible for many reasons. And you documented all the attempts to contact the patient in their chart. Tell me about the process for properly marking a patient inactive.
Well, let me first compliment you by saying that you documented all the attempt to reach the patient, because that's one thing that I see a lot is lack of documentation for missed appointments or attempts to reach the patient. First of all, when you're ready to dismiss a patient, it's a sensitive process. And what I say to everybody is include it in your office policy at the very beginning, during the intake process. Patient is new, and you're talking already about dismissing patient. Yes, because I just planted this seed in their mind. So if things go south at some point, we have a clear office policy. The patient is aware of it. And also, as you're discussing these office policy, is the patient going to play by your rules or not? This is, again, when you embark on treatment and accept the patient, they need to understand that you have a policy, and if they're playing by your rules or not, it's time to decide early on. It's a sensitive and a delicate process, and it has, legal implication, patient abandonment, and so on. And you got to follow the proper process. So before you take any steps, like you said, you want to review the records. You want to make sure that you have entries about the no-shows and everything else on your attempts to reach out. If we were focusing only on the patient that has a little bit of treatment and you attempted to reach, then you want to document this and you send a letter. We've attempted to reach you so many times, and you send a letter. And I usually would say you send it, one is certified with return receipt requested and one just regularly. So you cover both bases.
So if you have the patient that isn't going to play by your rules, or let's say they need medical clearance, or maybe they were referred to a periodontist for treatment prior to completing a restorative treatment plan, what is the responsibility of the dentist to follow up with that patient? How do you best document it, and how to ultimately dismiss the patient if it's necessary without it being considered abandonment?
Well, you referred the patient and the patient does not follow your treatment recommendations, and you attempted and you documented how you attempted, whether you tried to reach them or you brought them in or you had a conversation. If there is such documentation, then dismissing the patient for not following your treatment recommendation is a very valid reason.
So if you can't reach the patient, should you reach out to the specialist and find out what they have documented for that type of contact?
It doesn't hurt. Absolutely. It doesn't hurt. And you document that this is what you did. I mean, sometimes what you just said is very valid, because let's say the general dentist refer them to the endodontist, and they go to the endodontist, and while they're at the dentist, they say, you know what, I don't want to go back to this general dentist. Can you refer me somewhere else? We'll leave it at that. But they decide not to contact you anymore. Then you call that endodontist, like you just said, and you find out what's happening. And if they came and they got the treatment done, but then later on they decided not to come back to you, again, documentation. You document every single step, and at some point you send that letter like we have, and the sample letters, and send it. Yeah, very much so.
I'm learning a lot because a lot of these things I'm throwing out to you are things I've either read or experienced. So let's say that I'm an office manager right now. I'm listening to this podcast and I'm enlightened by the information and this conversation, and realize that maybe we need to tighten up some of our policies on patient dismissal, do better at documentation, or question anything else that you and I have discussed that gives them reason to pause and realize that there's room for improvement. If the dentist is a client with dentist choice, can the office manager reach out proactively and speak with the risk management specialist for advice, or is that limited to the dentist because they're the policyholder?
No, the office manager can call, and it happens all the time. And we give advice if they're insured. And yeah, absolutely. And it's a safe space, that there's no condemnation. There's no record. Well, there are records, but it doesn't affect the standing of the insured. This is a safe space where we keep record just so we know that we returned the call and we know that we're on top of it. But it does not affect anything else. This is a safe, confidential place where you can call with questions. And the earlier you call, the better it is. You don't want to wait too long, and then you call when things have already progressed, because then you're in a weaker position.
I think you and I could continue this discussion for hours. I'm not sure that we would retain a lot of listeners for that amount of time.
Yes.
But it's an important topic to discuss and to give advice that helps our members be more prepared and inform some on how to use their malpractice insurance to help avoid claims and be best prepared should that horrible position arise where they have to defend themselves against a claim. And this is just one small avenue for education. There are more resources on the Dentist Choice website. And dentists that are insured through Dentist Choice have annual education with CE credits available to them, correct?
Yes. And also, if a case that's not clinical, it goes to an attorney, very competent attorney, very competent risk managers. Absolutely.
And on that, that annual CE that's available, does that provide a discount to them at all?
It does. I don't know how much, but it does.
Okay. And would the office manager be able to participate in that education?
Absolutely. And we encourage it. We encourage office manager and staff because they are the ones that interact and interface with the patients. All team members have a significant impact on interaction with the patient and the dentist-patient relationship.
I'm glad you said that. I think maybe because I was an office manager and enjoyed being one, people hear me preaching about engaging with the office manager, but I think it's important that you empower your team to support you. And a lot of this information they don't have access to.
I can't tell you how important it is to have the right people and train them properly, just like you said.
I'm going to put you on the spot, Dr. Rizkalla, and ask you to give VDA members a take-home message on this very important topic.
My take-home message would be, number one, is keep with advances in our profession and deliver evidence-based care. Stay within your lane. Don't exceed your level of ability, and know when to refer to a specialist. Document documents. And of course, hire the right individuals and provides thorough training on regular basis. On regular basis, that's important. And finally, treat your patients as you would want to be treated.
That is truly sound advice. I would love to thank you, Dr. Rizkalla, for your expertise and guidance, and I'm positive this was helpful and thought-provoking for our members. We'll have contact information for RK Tongue, Dentist Choice Malpractice, and Office Insurance, and for Dr. Rizkalla, the Head of Risk Management. That'll all be in the show notes. We will also include direct contact info for Mike Urbanik with RK Tongue, because he would be the best person to reach out to with general questions about malpractice insurance policies. Please like, subscribe, rate, and share this podcast. Let us know if you have any suggestions for future topics, as our goal is to bring relevant and helpful content to VDA members and their teams. Thank you for listening, and we look forward to having you return for the next episode of The Fulcrum.